Welcome to Transforming Medical Communications, a podcast by MedComms experts. We share medical communications insights and advice from the best and brightest in the industry to find out what they're doing to push our industry forward. Here's your host, Wesley Portegies.
Welcome to Transforming Medical Communications. I'm your host, Wesley Portegies, and today we're joined by Denise Clark. Denise is a seasoned leader in field medical with over 20 years of experience. Much of it focused on advancing strategy and education in rare diseases. Denise has played a key role in onboarding, training, and mentoring MSLs, and her passion lies in redefining how field impact is actually measured. She brings a bold perspective on why traditional metrics, like counting the number of interactions with HCPs, often miss the mark. In this episode, we'll explore more what meaningful impact actually looks like, how we define outcome-oriented metrics, and what it takes to align leadership and cross-functional teams around a more holistic view of value. Welcome, Denise.
Hi, thank you. Thank you for having me, Wesley. It's nice to be here.
It's my pleasure. Denise, before we dive into detail here, it would be great to learn more about how you actually ended up in field medical. So what was the defining moment that drove you to field medical?
Sure. I actually love this story because it goes way back to pharmacy school. So I'm a pharmacist by training. I have my doctorate degree, PharmD. And I was in the second class of the doctorate program at my school. They had just gotten accreditation. And one of our professors was lured to the dark side, as they say, and became an MSL. And she came back a month or two later and presented to us, kind of described what she was doing and what the job was. And at that point, I was like, that is what I want to do. That's what I want to do. So I went to her and asked, what do I need to do to be an MSL and work in industry? And so at that point, as you mentioned, over 20 years ago, it was mostly very seasoned, experienced PharmDs, MDs, PhDs that were being hired. And so she told me, be sure, go get your residency, get some clinical experience, and then, you can jump in. I did that. I went and completed my residency and became a clinical pharmacist for a very short stint because I was very lucky and I was able to get into industry as an MSL at Wyeth Ayerst when it was Wyeth Ayerst. And it's been a wonderful experience. And what makes it so fulfilling for me is when I became a pharmacist, I wanted to help patients and I loved doing counseling and educating patients. In industry, as a medical science liaison, you have a larger impact. So not just on individual patients, but through education of healthcare providers, you can have impact on a larger group of patients, a patient population, and better their care. So that's my story.
Beautiful story. And quite uncommon. Like I know a lot of people, they want to become an MSL. There are whole communities out there. So congratulations on how you got into field medical, and it's exciting to see that you have been there for so long already.
Yes.
So I think we could maybe take this as like, why don't we go through a chronological story of MSL interactions, right? So the first thing someone were to do is some pre-call preparation, so pre-meeting preparation. What would you say are 2 or 3 essential things that every MSL should prioritize during their pre-call planning to make sure that they have high value and very relevant conversations?
Yeah, absolutely. When you become an MSL, you learn all this scientific information and you are supposed to be the expert in that field. You know everything about your therapeutic and you learn as much as you can about the disease state. And you want to share as much as possible, but that is not the role of an MSL. You can't just be transactional and for lack of a better word, vomit out every detail of data that you know. So you have to plan that interaction and determine what your goal is. So I like to go by 3 letters, B, G, and Q. So learn the background of the HCP. And that goes to publications, their therapeutic expertise, if there's a specialty or interest that they have. And you can see that through their publications. And many times organizations have platforms that allow you to see this background information. In fact, one other aspect that's very helpful, if you're able to do it, is reach out to your sales partners. They know the ins and outs of the HCPs they call on. And one thing that you're not going to find in your research is if Dr. So-and-so moved away from a practice and there was kind of a divorce between these two physicians, you've got to know some of that background because you don't want to bring that up in your conversations. And then lastly, middle goal. Goal. So determine what your goal is. So if it's the first time to meet the HCP, obviously your goal is to meet them, introduce yourself, and learn more about them. And then the last one, Q, is developing key insight questions or conversational questions. And those questions will allow you to not only be able to share your information that you want to share, but gain insights and find where there's a gap for them and the possibility that you might be able to fill that.
This is really intriguing. So BGQ, talking about the goal and the questions, like you gave an example of a first time visit, but let's say you're able to further into this journey with the particular HCP. How would you update your goal and what would be a way to define questions in advance?
Sure, absolutely. So I think it's very important just on an organizational standpoint to come up with kind of a scientific strategy of what's the narrative or the journey. So you put physicians on a spectrum, 0 being no knowledge. So for example, you're supporting a rare disease product. They might not know anything about this rare disease. So there's 0 all the way to 5 where, they are talking about it. They're tweeting, or I don't know. Do you call it Xing? I don't know. Digital education about the topic. So you have this spectrum of no knowledge to they're sharing the information on their own from the podium or digitally. They're speaking on your behalf, etc. And so you want to, as a medical science liaison, move them along that spectrum. So it's important to have that dictated and kind of spelled out in regards to your disease state and therapeutic area. And that helps you define where your goal is going to be, dependent on where they are in that spectrum. So.
Yeah, I really like that. Actually, here at MCE, we have been working on a framework. We call it the SPICE framework. And it actually was derived from a more sales approach, which we obviously don't use in medical affairs, but there's something called spin selling. And it's kind of an approach where you kind of determine where the other party is in their journey from, maybe in this case, being aware of the problem to being an active collaborator, or maybe an investigator on one of your studies, right?
Right.
And then there are certain questions that you can use to bring them along on that journey. And so it's kind of funny that we have similar thoughts about this and how we can bring these people forward from being potentially unaware of a certain fact,
right,
to become collaborators with us. And I think questions are very powerful.
Right. And it's key to get away from those yes/no questions. Do you know about this? Do you see these kind of patients? They're going to say yes or no, and you just didn't gain any information. So they have to be much more open-ended to learn more about that and have that conversation. Now, granted, we all have days where you didn't hit a home run in your interaction, your appointment with the HCP. They're bogged down. They're writing in the chart while they're talking to you. You don't have eye-to-eye contact. But many times, depending on the question you ask, it can stop them in their tracks, and they'll look up and answer the question. And I think it helps you in profiling when you're first going in, even pre-launch, to learn more about the experts in the area. And then also as you continue that relationship and learn from them, it's really, really important to understand that it's a two-way streak. So you're not going in just to go in and have an interaction. You're going in to make an impact, teach, educate, but then also learn. Because if you find those gaps, there may be a way that you can fill those.
Yeah, I really like that, the two-way street concept. And it is, I guess that brings it to communicating with context and purpose in mind, right? So
Yes.
you already said that delivering data or data dumping, so to say, is obviously not hitting the mark. So how would you say is a more strategic and contextual interaction different from a transactional one?
I know we're going to talk about it, but it kind of goes to the measures that you're looking at. So if the measure that is being evaluated is purely number of HCP interactions, then, technically you met the goal, you checked the box because you met with them. So in that realm, if that's solely what you're looking at, and hopefully that's not at any organization, that's what you get. And that's not what we want. And so it's important to look at what the goal is and then have that interaction so that you're not just checking a box, that you're having impact to improve their education and really move the needle on how patients are treated or medical practice. So for example, I'm trying to think of a more generic example that I can share. So if you ask the right questions, you may be able to determine that there is a different way or means of treating patients with your therapy. So for example, and this goes into insight generation also, which is also another measurement of our impact internally, because organizationally we bring this information back. But if across the country, MSLs start learning about a physician combining your product with another product and it impacting the efficacy and or the safety, this is something that is very important. And then when analyzed from a national level, you see those trends that then could lead to the advent of a clinical trial to actually test that theory that this physician has had in using this combination. And then that can lead to a label change and potential improved trajectory on the product and expansion of the patient population that's eligible.
Yeah, absolutely. Now going back to the quality of the interaction, what are some, maybe if you look at like the best MSL interactions you have ever seen, right?
Yes.
What are some of the behaviors? What are the specific things that these MSLs do that make it so meaningful and quality? Let's do one step back. So looking at the more specific behaviors of MSLs that you have seen that are performing really, really well, what are some of these things that they do that make their interaction so valuable?
So we already mentioned the pre-call planning. And so if you learn some different areas of interest of that HCP, for example, certain publications, you may be able to tie that to the area of conversation that you're going to have. So you're going to file that in the back of your head so that when you're having your conversation, if it fits in, you can bring that up. But I think there's a few areas that MSLs need to be comfortable with, and that's having an open conversation and closing the mouth and opening the ears. Listening is very important. Obviously, asking those questions gets the other person to speak to you and provide information. But the goal is not to speak more. The goal is to listen more, right? So be able to listen and then take those cues to pull the information that you've learned behind the scenes and potentially translate that to connecting the dots with the physician and or provider, and the eyes open up and they get their interest piqued, and then you can move to another area of conversation. But you have to be able to be comfortable and confident in having those conversations and not be as bogged down in knowing all your data. It's really important, but I think especially early in your career as an MSL, you get so nervous about knowing all the numbers and all the data that you are constantly thinking about that in your head, and it may detract from your ability to listen and learn from the HCP you're talking to. A lot of times I go in with that aspect that I'm learning from them. They call them key opinion leaders for a reason. I'm not the one that's treating patients. They are. So there's so much more that I can learn from them and potentially share back internally, but also potentially share with other providers. So very key to listen, and then be sure to jot those down after your appointment so that you have those to take back for insights.
Yeah, it makes me think about like the rules, for consulting or leadership for that matter, right? Where they say like you should be speaking 20% and listen 80%.
Yeah.
Which, like, if you think about it, if the mission you're being sent away with is like you need to educate people, like you might automatically feel a little bit of this drive, like, oh, I need to pump as much information into that meeting as I can in the 10-15 minutes that I have. But actually, sticking to the 20-80 might be a better result.
Right. Well, and a good example of that is if you are launching a product in a new therapeutic specialty, and they have they haven't traditionally treated that disease state. For example, in my past, I had a product for anemia, and it was approved for anemia and CKD. Well, we weren't calling on nephrologists. We were calling on hematology oncologists. Well, what are they going to say? Well, we don't have CKD patients. So you have to listen and find out what their patient population is, but you can also educate them in showing them through data that they actually do have those patients. And then that's the first step. So they have to identify. But if you don't do that and you jump into your drug or the disease, they may be courteous and listen. And I imagine the Charlie Brown, cartoon, the wah, 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 because they're not really listening. That you leave and they have forgotten it immediately because they're like, this is not a topic that is of interest to me, and I don't see this on a daily basis. So you have to make it connect with them and an important topic for their practice. If they don't see that relevance, then they may be nice and let you speak and talk to them, but it's not making an impact.
Yeah, that's a good point. And it actually made me think about two different things. You might be familiar with this. Every 5 years, McKinsey brings out this like Future of Medical Affairs white paper, right? And I remember the 2025 version, it said something like 81% of healthcare professionals feels that like content provided by pharma isn't necessarily relevant to them, right? So I think that relevance is really the key word in everything you said. We're working with like a lot of people to train them on storytelling techniques. And one of the basic premises of storytelling is that you're making it actually more relevant to your audience and help provide that context. And I think that is really important because as an MSL, obviously it's all about the data and all about your products like all the time. You're working on that 40 plus hours a week.
Yes.
For an HCP, it's just a part of their professional life, right?
Exactly.
They have many other things to think about. So I think it's really key to provide that relevance, and that will help them also remember and recall the information better.
Right. Yeah, the story is very important, and I try and simplify it. There's no need to become all technical just to prove that I'm smart. If I can make it easier to remember, and then also keep in mind and apply the patient to it, I think that tends to also resonate with healthcare providers, not only the physicians, but nurses. And so I try and always bring a patient into that conversation so that I'm not just talking about this disease or this drug. I'm talking about the impact on that patient. So quality of life measures are always very helpful when you're doing that too.
Yeah, absolutely. Absolutely. What do you feel that field medical leadership could do more of to help MSLs embracing skills like these?
Yes, I think overall, the training at the time of onboarding definitely focuses predominantly on the knowledge of the disease state and the product. And we need to incorporate into that kind of the soft skills that are required as an MSL. So, for example, instead of having, quote, knowledge checks, which are really factual, and this is the percentage of, efficacy in the study, and this is how many patients, you can incorporate that knowledge check by putting a scenario together. And I know none of us like doing role playing, but it is very helpful to either do it as a role play or just conversationally talk out how you would address that scenario. And if it's a product that's been out, this is pre-launch, there's that experience, then those scenarios can be based on what the current MSLs are seeing out in the field. And that better prepares the new MSL in how to address those type of questions and scenarios. And I say scenarios because they might not be questions. They might be just a statement, and it's a statement opposite of what we're trying to do. So how are you going to integrate questions and further that conversation with that HCP and have that conversation? So there's no right or wrong answer in that kind of training.
Yeah, I like that. And I think I couldn't agree more that practicing that is so important. And I think especially in this really highly complex industry that we operate in, right?
Yes.
Everything is very technical. So the soft skills side shouldn't be forgotten.
Absolutely. And then you can incorporate, as you continue, best practices, periodic training calls. I don't like to call them training because everybody goes, training. But they're conversations, discussions to further talk about how you address certain scenarios and situations. And then as you gain more resources or there's new publications, you can then develop a plan in how you're going to integrate that into your conversations. And so again, it goes to kind of real world scenarios instead of just, this is what you're going to do, this is what you're going to talk about. You talk about how you're going to talk about it.
Yeah, exactly. Yeah. I like that. So now let's say that leadership does all of that, right? And the quality of these conversations would go up. We would want to know how we know that the quality is going up, right? So I guess we're entering, I know you're very passionate about this topic, so we're getting there.
Yeah.
So why don't you tell me a little bit more about how you feel about, the current practice of measuring MSL or field medical performance?
Sure, absolutely. So this has been the $1 million question since I started in field medical affairs. Traditionally, we can't tie sales numbers and revenue and dollars and cents to the work that we do in medical affairs. It has to be independent of that. And so when we look back, traditionally, a lot of the metrics or measures that have been used translate from our commercial sales colleagues. They look at reach and frequency, correct? And with reach and frequency, that also translates to the next number, which is sales. So those activity type metrics means something that's connected to the sales number. So if you increase reach and frequency, hopefully you're going to see an increase in sales. That has been used now in field medical. How many HCP interactions does the MSL have? Unfortunately, that number is not tied to anything. So from an organizational standpoint, what does that really mean? And I know that it's important. In order to have an impact in field medical, you have to have the interaction. So there's no way around that. You have to measure that. But I don't think it should be the headline. It should be the footnote. In other words, we should be looking at the impacts of those interactions And when I say that, it depends on the therapeutic area and what your goal is in regards to what you're measuring. But then the footnote should be, we accomplished that through this many interactions. So a simple one to talk about is, for example, in rare disease especially, you have a disease state education initiative where the MSLs are sent out and said, you need to do a certain number of educational presentations, programs. And you can do that. And each MSL, let's say 2 a year, we'll put that out there and check the box. They do 2 presentations a year. So what does that tell us? We find out that there were 25 butts and seats, but really doesn't tell us much more. What did the HCPs take from that education? So a simple way to look at that is you can incorporate audience response. And I know our CME colleagues have been doing this forever, and there's pluses and minuses, but you're able to put in very strategic questions at the beginning and questions at the end, and possibly in the middle, even open text to get directly from your audience, the HCPs, not filtered through the MSLs, data on what you're accomplishing, what they learned in those programs. You could even take it a step further in regards to follow up with those HCPs and look at medical practice. And so that's where we're getting into now, where organizations are now utilizing claims databases to determine potential impact from their medical affairs departments. There's a lot of assumptions in there, and it depends on the therapeutic area. So you have to start with what your goal is and work backwards to determine how you best could measure that.
I like that. Hey, we need your help. The best way to help us grow and reach more medical affairs professionals is to share with your community. If you love our podcast, please hit subscribe, leave us a review, and that way we can keep sharing insights from the best and brightest in the medical communications industry. Let's push our industry forward together. Because of course you could have like 10 terrible presentations or interactions.
Exactly.
Or 10 really good ones, right? The number is the same.
Yes.
The outcome is not.
Yes.
So could you elaborate a little bit more on what meaningful impact means in that sense, in the context of field medical, and also what would be like a few concrete metrics other than the ones you already mentioned that would help us capturing the definition?
Sure. So I can only answer that question with kind of an example. And this would be operationalized differently at different organizations. And like I said, it really depends on the therapeutic area. So let's say that you are an organization that has a first-in-class only treatment in a rare disease. This just happened multiple times just recently. This is a really perfect place to have a good baseline. And part of rare disease, unfortunately, is this gap in diagnosis. It takes a significantly longer time to diagnose rare diseases, many times because they're rare, and so it's not top of mind. And so a lot of that is going through looking for a needle in a haystack. So you have a baseline, and maybe your goal is to improve identification and diagnosis of X rare disease. That could be done, again, you have to have a baseline in order to measure this. That could be done through looking at claims databases on screening, if there's a certain lab test that's done and wasn't done regularly before, so you could see that impact. You could also look at diagnosis codes for that or related diseases. That's just one example. And then you can get to it even more. I had a colleague push back once and said, well, yeah, but everyone has an impact on that. It's not just medical. And my response is, yes, we all have the same goal. I think that's a great thing. It's share a voice. Even though we're not in sales, we all educate on the disease. But we can look at it if you look on an HCP level. So it would be interesting to look at HCPs that have no interactions with the company compared to HCPs that are seeing sales, seeing MSLs, and or the combination. And again, not looking at sales numbers because this is medical affairs, but looking at diagnosis or lab codes, et cetera. So it really depends on the disease state to look at those.
Yeah, that makes sense. So we need to find non-economic value drivers.
Right. I like that.
Yeah. So imagine that you are responsible, or you probably are, I guess, designing a metrics framework for field medical from scratch. Where would you start? What are some data sources? You called a few out, and also maybe some qualitative signals that you could use, or behaviors from MSLs that you would prioritize.
Yeah. Well, I am not responsible for that. I would love to be, but I'm not right now. This is definitely something that's important to me. And I go back to kind of my experience as a clinical pharmacist. It's almost like job justification, right? And everybody hates to hear it that way. But if medical affairs and MSLs don't define their value, it will be defined for us. So we have to do that. And I think the key thing is really jumping in and identifying one measure, not telling anyone, and going back and seeing if there was an impact. So you'd have a retrospective analysis. You'd pick a time point as your quote baseline, and then you'd move forward to a time point that's recent, et cetera, and see what that change is. And imagine that meeting with leadership when you present in graphical form this dashboard that's showing this impact. And then, like I said, the footnote is through this many interactions or this many programs, et cetera. I think that then would pique interest, and there would be a better uptake of those kind of measures. The unfortunate thing is that some of these measures take time, and a lot of the reporting is done either on a quarterly basis, semi-annually, or annually. And some of these don't happen that quickly. If you want to see an uptick in the diagnosis of a rare disease, or even just the screening really probably is what you want because it's rare, of that disease, it's going to take time and share of voice and education and multiple different initiatives to do that. So it may not be in 1 year, maybe it's in 2 years. So, but you can go back retrospectively if you're not at a launch. You can go back retrospectively and evaluate that.
Yeah, that makes a lot of sense. And I think that's generally a little bit hard in our industry. It made me think about content strategy, right? Like we want immediate impact.
Right.
And it might even be there, but you can't really measure it. It's a long-term strategy that you need to keep sticking to and kind of consistently roll out over time to start seeing the results.
Right. Because there's quantitative measures there that we report for scientific communications. How many publications, how many abstracts were accepted. But at the end of the day, maybe those are all important. They're good because you have to have them out there in order to make an impact. But then at the end of the day, maybe how many times is it being referenced in other articles, or how many times has somebody reshared it online or quoted it? Those measures then show that, it did have an impact, and that can increase over time. So there's quantitative and there's qualitative, but it really depends. Again, it has to be customized to what the goal is in the therapeutic area. Because if you're in a crowded market of 6 different agents for the same disease state, it might be much more difficult to tease out the impact of your medical affairs department.
Mm-hmm. Are there certain leading indicators that could help with that? I'm kind of thinking about the reality of our situation, which is we probably have some quarterly goals,
Yes,
and maybe annual goals, likely, maybe a 5-year goal, right?
Yeah.
But the first 2 definitely would need to be seen by leadership,
Right.
to understand whether they're on the right track. So how do you go about this longer term meaningful impact versus the shorter timelines that you would need to measure it in? Do you see any solutions for that problem?
That one's hard. Yeah, you're going to have to cut this and edit it. I'm trying to think. You have to have both short-term and long-term measures. And so my example of, the audience response system in presentations, that would be short-term. Long-term, as I mentioned, change in ordering a laboratory may be longer term. I don't know. It might be shorter, but you can't set an artificial 1 year and expect, a change in medical practice. In my mind, that's kind of an overnight thing. And that's not something that happens overnight, but all the additional pieces, like you mentioned, medcoms, we all play a part in that impact. At the end of the day, we all have the same goal. And I mean, everyone within the organization, the right patient at the right time with the right treatment, getting it safely and effectively, right? And so whether that's through our sales counterparts, our psychoms, internal medical affairs, and or our field medical, we all have that same goal.
Would you agree that in a way, like maybe some of the quantitative metrics that maybe don't tell us that much about the actual meaningful impact could potentially be the leading indicators, right? Like I'm kind of brainstorming with you here.
Right.
Like if you do the number of visits and assuming that you deliver them in a certain quality, then that would be maybe the leading indicator, while the lagging indicator would then be the change in medical practice. But you need more time to show that. So perhaps do you imagine there's a world where both of these things actually count and where they can work together?
Oh, absolutely. They have to work together. So definitely. I think I learned about I'm looking at my notes because I made notes of this one thing I wanted to share. Okay. I learned last week, or I guess it's been 2 weeks since the Medical Affairs Professional Society meeting, of this theory, and it's called Goodhart's Law. And it essentially says that when a measure becomes a target, it ceases to be a good measure. And in essence, we're going to go back to that number. You're required to see 30 HCP or have 30 interactions a month. Essentially, the goal is that impact. At the end of the day, we want, and I think that's job fulfillment for any MSL, is to have impact and see that the light bulb go on with their HCPs. But at the end of the day, if we have to get 30 interactions, then the focus becomes on getting the number of interactions and essentially checking the box, and not necessarily the quality or the impact of and the goal behind why we are getting those interactions. And that's why I say it shouldn't be the headline. It should be the subtitle of what we are presenting as the impact of MSLs and measures. Because truthfully, what does it mean? It means they saw that many HCPs, but do we really know if they just shook hands and said hi, or if they actually spoke about the disease state and made an impact? So again, it's Goodhart's Law, and I think we've seen this. I think of the 2016 scandal of Wells Fargo and the tight quotas of numbers by the bankers, and how unfortunately they were unscrupulous, and because of the pressure put on them, they didn't do such good things. I don't think that's going to be the case. This isn't that way, but those numbers don't really mean anything. So junk in is junk out, if that's the only focus that you have at the top. So you have to focus on what the true goal is and how we're going to get there and the impact. And we have to develop and determine how we can measure those. And today, with big data and the advent of AI and natural language processing, we should much easier be able to look at these kind of outcomes and measures to determine the impact of our MSLs and our field medical professionals.
Yeah, I completely see your point. And I've had a lot of discussions with with field medical people also around like, okay, how could we check? Could we simply ask? But then it's like, it's very hard to ask someone like, well, doctor, what do you think about this interaction, right? Like, did we educate you? That doesn't really work either, right? So it's very hard to kind of get like the feedback loop completed.
Right. And there have been organizations that have done that. They've sent out surveys to HCPs, and I think you may know the stats on it, but many times, unfortunately, physicians don't know the difference and identify the difference between the MSL and the HCP. And so, I mean, the MSL and the rep, I apologize. So scrap that, edit it. Okay. So many times the physician may not recognize what the difference is between the sales rep and the MSL. Now, granted, if the MSL has a relationship, so they've seen them multiple times, they likely know who the MSL is versus the rep. But if it's only one or two times in a very long time, they may not recognize that and be able to give a true answer. So there's pluses and minuses to that. And then just the percentage of response is probably quite low.
Yeah, absolutely. And I've actually some firsthand experience with this, and I have the same experience that they often actually don't know who the MSL is or who the sales rep is, or like they might know the people, but they don't necessarily know the difference. And talking about demonstrating our value in medical affairs, I personally think there's a case for MSLs to explain their role actually better and more.
Absolutely.
And kind of keep reiterating that over time as well.
Absolutely. And if they show value to the HCP and differentiate that, it will be very clear. If you are doctorate level and you go in with a rep that introduces you, I firmly believe they should introduce you with your doctorate, your Dr. Denise Clark, and then you clarify as you talk to them in regards to what kind of doctor you are. But that differentiates. Most of the time you're not introducing, a rep's not coming in saying they're Dr. So-and-so. And so that sometimes helps differentiate. But then you become a resource of information and knowledge, and that also helps differentiate your role.
Yeah, absolutely. What are some of the common mistakes that you have seen in organizations where they're trying to switch from these more quantitative measures to more qualitative measures?
I think, I don't know if I've seen personally mistakes, but I can definitely give you some scenarios of what I potentially think that you would see. And one of those is just dropping the numbers completely and we're not measuring those. That's not what we do. Do as an MSL without any resources and or training behind that. And I think that's really important. I had a mentor that used to say, if I give you numbers, I know you'll get numbers. And it goes to what I just said. And so I have been with multiple organizations over the last several companies that have not focused on those numbers. And I think from a leadership standpoint, the first pushback is, well, then how are we going to know that the MSLs are doing their job? How are we going to know that they're going out there and doing, meeting with HCPs? They could be sitting at home, eating bonbons. I hope as leaders, we know where our MSLs are and how they're doing their job. And a lot of times over my experience, that feedback comes from the field teams. So depending on the organization and the differentiation and separation of field sales and medical affairs, if there is some overlap, you will hear if your MSLs are out and they're doing a good job, because that goes back and gets back to the sales team, and the sales team then shares it. And it's very important there. The other thing, like I mentioned, is then not providing training in regards to what the why and the goal is. And I think that why is really important, and you have to break it down So you give the big why and what the goal is, but then you've got to tell them how we're going to get there and what the plan is. So you've got to put that in steps and document that so that it's widely understood by the entire team.
Yeah, absolutely. Now, Denise, imagine that tomorrow you're entering some kind of new organization and you're tasked with making this change. So far they've been using all these quantitative metrics and you're hired because they want to turn the organization in an outcome-oriented organization.
Yes.
Where would you start? Can you give us like kind of the rundown of the different steps you would take?
Absolutely. I think first I would step back and learn. So depending on where they are in the stage of development, if this is pre-launch, launch, the product's been on the market for several years, I'd want to learn that and then dig into the disease state. You have to learn that to find where the gaps are. And I think a big part of that is where the gaps are in patient care so that you can determine if potentially your organization, your product, et cetera, can fill that gap. And that would be a nice way to focus on an outcome. But you have to, again, I keep saying it, it's definitely customized to the therapeutic area to determine what you would be measuring. But I think it's key to sit back, ask questions, and learn more. And then also meet with a few experts in the area too, so that you can learn from their perspectives. So key opinion leaders in that disease state, find out what they see as the gaps also. And I think it takes a team of people brainstorming. It's not going to be one person because I think teams collaboratively come up with much better ideas than just one person. I know there's amazing people that can. I mean, we got Steve Jobs, but collaboration and a team approach to developing a plan of action in regards to those measures and the goals over time is more important. When you work in teams and you collaborate, you're able to get more buy-in, not only above, but from below also.
Yeah. So involving everyone in how to shoot for success.
Yeah, absolutely.
Yeah.
Absolutely.
Teamwork makes the dream work, right?
Yes, exactly. Another key point there, unfortunately, is technology. So you can't do this with Excel spreadsheets. Oh my gosh, it would be so tedious and no one wants to do that. So the use of technology and the potential implications of using AI would really help streamline that approach. And I know some organizations tend to be a little bit nervous and scared about utilization of AI, but in my experience, it's amazing to see how quickly and efficiently it can evaluate and analyze data.
Yeah, absolutely. That seems to be the superpower of AI, right?
Yeah.
And, in the beginning, I spoke about this 80-20 rule, like who's speaking how long. Like even the software we're using here today to record this podcast will tell me that, like, Wesley, did you speak enough? Too much? Like these kind of things. So I would agree, and especially with the proliferation of virtual MSL visits, I think, of course, we'll get more data to be analyzed. It will definitely take some time to adopt more of that, but I think there's an opportunity there for sure.
Virtual MSL. I think there definitely is a place for that. I kind of have said that it's MSL on demand, and that MSLs can't be everywhere with our sales colleagues when there's a question. And so if there's the ability to pick up the phone and call or get online to do a virtual interaction with that HCP, you would be able to immediately provide them the answer to the information they need. And that is impact. And it's also a good representation of your organization because you're working together to fulfill the needs of that provider. So I definitely, I look at MSLs as field medical information professionals. We're no different. We're just in the field, right? And so if we can help serve that way also, because we can't be everywhere all the time, but have access and ability to do that, that's great.
That's a good example of cross-functional thinking, which we need more and more of in medical affairs, I would say.
Yes.
Connecting the silos, right?
Absolutely.
Well, Denise, it was so much fun to talk about this with you. I could go on for some more time, but it's time to close our episode soon. But before we do so, I wanted to ask you, what is something that you would like to hear about in terms of topics in future episodes from Transforming Medical Communication?
Oh, that's a good question. I think from a field medical standpoint, this obviously is a very hot topic. I'd love to hear a case study of a specific scenario, which I think most of the time is very hard to do because of proprietary information, but where metrics and measures of impact have worked. But I also have interest in the utilization of AI to evaluate insights and coming up with directed insight questions and bringing those internal and evaluating those through AI. Okay. Oh, one more, which is really cool, and it's not my area, but the integration of digital technology and medical communications. So, for example, interactive posters or the add-ons to publications. I think those are amazing.
Great. Well, I happen to be very passionate about that topic, so we're gonna make that happen for sure.
Yes.
Well, Denise, thank you so much. Thank you for sharing all your insights with our audience today. Really exciting, and thanks again.
Thank you. I appreciate you having me today.
Transforming Medical Communications is brought to you by MedCom's experts. To find out more about MedCom's experts and how we create some of the most cutting-edge medical communications programs anywhere in the world, visit www.medcoms-experts.com. And then make sure to search for Transforming Medical Communications in Apple Podcasts, Spotify, and Google Podcasts, or anywhere else podcasts are found. Make sure to click subscribe so you don't miss any future episodes. On behalf of the team here at MedCom's experts, thanks for listening.